Our second speaker for today is Dr. Andrew Kolodny. He is the Chief Medical Officer of the Phoenix House, a nonprofit addiction treatment organization, and he is the Executive Director of Physicians Responsible for Opioid Prescribing, or PROP. Dr. Kolodny was previously the Chair of Psychiatry at Maimonides Medical Center in New York City. Dr. Kolodny has a long-standing interest in public health. Prior to his position at Maimonides, he was Medical Director for Special Projects in the Office of the Executive Deputy Commissioner for New York City Department of Health and Mental Hygiene. For New York City, he helped develop and implement multiple programs to promote the health of New Yorkers and save lives, including citywide buprenorphine programs, naloxone overdose prevention programs, and emergency room-based screening, brief intervention and referral to treatment SBIRT programs for drug and alcohol misuse. His talk today is entitled The Prescription Opioid Epidemic and the Heroin Revival. Thank you, Dr. Kolodny.
Thank you. It's a pleasure to have this opportunity to talk with all of you about the opioid addiction epidemic. I don't have much time, so I'm going to go right in. I have no relationships with pharmaceutical companies, and you'll understand when you hear my talk why pharmaceutical companies probably would want a relationship with me. So I'm going to start off by saying something that should be obvious, which is that when we talk about opioid pain medications, drugs like hydrocodone and oxycodone, we're talking about drugs that come from opium. Literally, to make oxycodone and hydrocodone, you start with opium. You start with the thebaine that's inside opium. And to make heroin, you start with opium. And when you actually look at the hydrocodone and the oxycodone and the heroin molecule, they're nearly identical. And the effects that hydrocodone and oxycodone produce in the brain are indistinguishable from the effects produced by heroin. What that means is that when we talk about opioid painkillers, we are essentially talking about heroin pills. Now, that doesn't mean we should never prescribe them. These are very important medications for easing suffering at the end of life. They're also very useful when prescribed to someone who's just had major surgery or a major trauma. In other words, they're good for acute pain when used for a few days. But the bulk of the US opioid consumption is not for end-of-life care or for acute pain. The bulk is for common chronic conditions where the leading experts who study them believe that opioids are more likely to harm patients than help them. So the CDC has been calling this the worst drug addiction epidemic in US history. And the reason that they're saying that is they're comparing our current drug problem with the heroin epidemic of the 1970s, which is right here, and the crack cocaine epidemic of the late 80s, early 90s. And what you see with these blue bars are the rate of drug overdose death. And what the CDC is trying to show us is that when you look at the rate of drug overdose deaths during the height of the heroin epidemic and the height of the crack cocaine epidemic, actually, if you put this box on top of this box and you drew a line across, you would see that we have far more overdose deaths today than we had at the height of those two epidemics combined. Now, this slide is old. I updated it right here to show you the total number of drug overdose deaths that we had in 2013, which is the last year for which we've got good data. But what I want you to understand here, this is 2007. In 2008, the bar went higher. In 2009, it went to here, 10, 11, 12, 13. It's gone higher each year, so that every year for the past 20 years, we've set a new record in the United States for deaths from drug overdose, and then the very next year, we break that record. Now, this is just showing you all drugs. It's not showing you what type of drug people are overdosing on. That's on this slide. And I started by saying that oxycodone and hydrocodone and heroin are all opioids. Here, though, heroin is shown in green. And in red, you see prescription opioids. You could see cocaine deaths have actually come down since 2006. The point on this slide is what's really driven this sharp increase in overdose deaths in the United States has been prescription opioids. Now this slide ends in 2010, so I'll show you what's happened since 2010. And we're focusing just on opioids. What you can see, the black line is showing you the total opioid overdose deaths. The red line is showing you prescription opioids, and you can see they've plateaued since 2010. And the green line is showing you heroin overdose deaths. And what you see is a very sharp uptick in heroin overdose deaths since 2010. Now, this sharp increase in heroin overdose deaths is leading to this popular media narrative, which I don't think is correct. What you're hearing is that the reason that that green line has gone up in the past couple of years is because of a crackdown on painkillers. That the feds cracked down on painkillers and it's created this new heroin problem. That's the story, and it sounds pretty good too. The government tries to do something good and now we have this bad, awful consequence. It makes for a good media story. I don't think that's actually what's happening. I would argue that the reason that the heroin line is going up since 2010 is because in 2010, the heroin supply became significantly more dangerous. Increasingly, it's got illicitly synthesized fentanyl mixed into it. We have not had people suddenly switching over to heroin. From the very beginning of the prescription opioid crisis, we've had people switching from painkillers to heroin. So it's not a new problem, the switching. It's been happening for a while, and you'll see that on this slide. On the right, you're looking at African Americans, and on the left, you're looking at whites. And what I want you to look at would be the red line, which is the age group 20 to 34 years old. And what you can see is that from the beginning of the opioid crisis, you've had young white people switching from painkillers to heroin. So not a new problem. It's been going on for a while. The other reason that the narrative that we've had this federal crackdown on painkillers and that's what's led to the heroin problem, another reason that it's not true, I believe, is that we really haven't had a federal crackdown on painkillers. I mean, if this uptick in heroin deaths begins in 2010, the closest thing to a federal intervention that would have had a real impact would have been putting hydrocodone combination products into the Schedule II category. That didn't happen until 1 year ago. That happened in the fall of 2014. So what is going on here? And that the narrative of people switching is accurate, but it hasn't happened suddenly. It's been happening for a while. And what's really happening is that there are two age groupings of people suffering with opioid addiction right now. There's a younger group that's switching over to heroin and an older group that doesn't need to switch, that's staying on painkillers. And you can see that here. So the age group with the highest rate of opioid overdose death in the United States are people who are right here, 45 to 54. The media focuses very much on young people who are dying of opioid, either heroin or prescription opioid overdoses, but it's actually middle-aged folks and older folks where we've seen the largest increase that are dying of overdoses. So there are basically two groups. What we have are people who are under 40 who are developing opioid addiction through either medical or non-medical use of prescription opioids. And when that younger group gets addicted, if it's a 25-year-old or 30-year-old who's healthy and now they're opioid addicted, they have a difficult time maintaining their opioid supply visiting doctors. Unless the doctor is really a drug dealer, they don't want to give 200 tablets of oxycodone to a healthy 30-year-old. Very quickly, that group would wind up on the black market. The pills are very expensive on the black market. Anybody know how much a 30 milligram immediate release oxycodone sells for on the black market? Maybe in some areas, because the prices do change. It's about $1 a milligram. So it's $30 for a single pill. The 80 milligram OxyContin was $80. And so it's very expensive. A $10 bag of heroin will do what that $30 oxycodone will do. So people switch. And if you were in a region of the country where heroin was available and you're a young person who becomes opioid addicted, you switch over to heroin. And what's happened over the past decade is that because the prevalence of opioid addiction has increased so rapidly, especially in suburban and rural areas, we've seen heroin moving into these communities to meet the demand for it. So we see heroin in quaint New England towns that had never before seen heroin. There's a very good book on this called Dreamland by Sam Quinones, which I recommend. But this older group, people in their 40s, 50s, 60s, 70s, 80s, that group does not need to switch to heroin. Even when their primary care doctor becomes uncomfortable because their dose might be escalating or they're coming in early or they look addicted, the patient is typically saying, well, I took extra pills, doc, because my pain was really bad. And the primary care doc who starts to get uncomfortable typically refers that patient to a pain specialist. Those patients are generally able to access pills. And I think that is why we see the higher rate of drug overdose death in the older folks who are getting prescription opioids from doctors, even higher than the younger group switching to the especially dangerous heroin that we're seeing. So you'll hear our opioid problem described in different ways. Sometimes people call it a prescription drug abuse problem, or you'll hear it described as a new heroin abuse problem. And I think calling it an abuse problem is not the correct way to define it, because I think it makes people think that what's really happening in the United States is we have a lot of people behaving badly. They're running around taking dangerous drugs and to feel good, for fun, they're abusing these drugs and accidentally killing themselves in the process. That is really the wrong way to think about what's happening. There's very good evidence that the vast majority of the overdose deaths that we're experiencing are not occurring in recreational drug users. They're occurring in people who've developed opioid addiction. Now, some people have developed opioid addiction through recreational or non-medical use. But again, many people are suffering from this condition because they developed it taking pills exactly the way the doctors might have initially prescribed. So if we think about this as an addiction epidemic, I think then the next set of maps I'm going to show you sort of can show you the epidemic occurring over time. So what you're looking at is, I would argue the epidemic begins in 1996, and you'll see why I say that in a moment. This is 3 years into the epidemic. And the states that have the highest rate of people showing up into the state licensed treatment programs saying that their primary drug that they're addicted to is a prescription opioid, the states with the highest rate show up as red or maroon. And I want you to watch what happens to the color of the map as we go forward in 2-year increments. So this is 99, 2001, 2003, 2005, 2007, and 2009. So what you can see is that in just about every state in the country, there's been this sharp increase in the prevalence of people with this condition. And when you have a sharp increase in the prevalence of a disease over a short period of time, that is how you would define an epidemic. So the reason that we've got overdose deaths at historically high levels, the reason heroin is flooding into non-urban areas, why we're seeing outbreaks of hepatitis C and HIV, why we're seeing rising rates of infants born opioid dependent, the real driver of the opioid problem that we're dealing with is this epidemic of addiction. It's the fact that the prevalence of this condition in the United States has increased rapidly over a short period of time. Now, this is really interesting. When you first look at this, you may not notice what's really striking about it. Something that's a little interesting is that the male and female peak is similar. You're looking at this was made with data, the same data that was used to make the maps. These are the people coming into drug treatment who are saying that the drug that their primary drug they're addicted to is a prescription opioid. And so with with heroin or crack cocaine, you would have seen significantly more male than female. Here you see a significant peak in young adults. There's this older group that's addicted, and we certainly see it in the mortality data. They're less likely to wind up in addiction treatment for a variety of reasons. In part, many of them don't see themselves as addicted because they're getting prescriptions from doctors. But what's really striking on this graph, and I don't know if anybody's picked up on it yet, the color of the line that we're looking at is blue. And what you'll see here at the bottom is that blue refers to whites. Try to find other racial groups. And it's not that whites are more likely to get addiction treatment. If I showed you the crack cocaine slide, you would see a red line for African Americans higher than the blue line. This is real. And so to say that this epidemic is disproportionately white is an understatement. It is really striking how white this epidemic is. And it's an important clue, I believe, as to what's really causing our opioid crisis. Because my best idea as to why this is so white relates to the way in which doctors prescribe narcotics. And this has been studied. When the patient is black, the doctor prescribes more cautiously. When the patient is black or Latino, the doctor appears to either be more worried about addiction or more worried about diversion onto the black market. And when the patient is white, the doctor appears to feel there's very little to worry about. What I think is happening is that racial stereotyping is having a protective effect. Doctors should obviously be prescribing cautiously to all of their patients. It's funny because the drug companies keep putting out these studies showing that we're under-treating pain in African Americans because we're under-prescribing opioids to that population, when I think we're actually over-prescribing to whites. So let's talk a little bit more about what caused this epidemic and what's fueling it. This slide was put together by Len Palazzi, who's a medical director at the CDC. He's the guy who's had this problem on his plate for a while. First time he did anything like this was in 2006. And Len is also one of the co-founders of PROP, Physicians for Responsible Opioid Prescribing. That's the group that I'm part of. So what Len did in 2007, I think, for this graph, what he did was to try and answer the question of what's causing this sharp uptick in overdose deaths. On this graph, he plotted out in orange deaths involving overdose from prescription opioids. And then on the same graph, in yellow, he plotted out sales for prescription opioids. And what he argued in this paper is that this epidemic has really been caused by the medical community. That as doctors began to prescribe opioids much more aggressively than we had, perhaps, I was going to say than ever before, but I've read David's work, and in the late 1800s was another period when doctors were prescribing very aggressively, and we had an opioid addiction epidemic. But perhaps any other time since maybe the 19th century, as the prescribing took off, that it led to this public health crisis. And in fact, this has become the chief speaking point on our opioid addiction epidemic from the CDC. And the CDC this is a little more current than the last slide. The CDC is making the same point. The green line represents opioid consumption in the United States. The red line represents deaths involving prescription opioids, and the blue line represents addiction. And what they're saying is that the green line is pulling up the red line and the blue line. And the CDC's message to the medical community has been very clear, and in fact, they're working on guidelines right now on opioid prescribing. Their message is that we may not be able to bring this epidemic under control until doctors and dentists and nurse practitioners and physician's assistants, until we start to prescribe more cautiously. They're saying that the green line has to come down. Obviously not all the way down, because these are essential medicines. The opioid manufacturers don't agree with the CDC. And I'm not kidding. I'm not kidding. What they say is that the green line can and should continue to go up, because this is the statistic, because 100 million Americans are suffering with chronic pain. But if we teach doctors what they call safe and effective opioid prescribing for chronic pain, if we teach doctors the right way to prescribe, and if we make the pills crush resistant, then we can have our cake and eat it too. The green line can continue to go up, and we can make the red line and blue line go down. This is I just put this slide together the other day. This is the latest data showing us consumption and overdose deaths. And what it's showing us is that the CDC has been right. They've been right when they started to say that we needed to bring down consumption in order to reduce overdose deaths. What we're seeing here is that as consumption plateaued, that it did lead to a plateau in overdose deaths involving prescription opioids. So I mentioned that the opioid addiction epidemic begins in 1996, which is pretty bold for me to say I know what year the epidemic started. Well, this is why I say 1996 was the year the epidemic began, because you can actually see the year that oxycodone prescribing takes off. And it takes off in 1996. Now, 1996 happens to be the year that Purdue Pharma introduced what drug? Anybody know? OxyContin. So, and what's the active ingredient in OxyContin? Oxycodone. So you might look at this and say, well, maybe it's that red line is going up because we had this brand new opioid on the market, and that's what accounts for that big increase. And it pretty much does. Prior to 1996, that was Percocet, oxycodone available mixed with acetaminophen. And then you had this new opioid on the market in 96, and so that's why the oxycodone explodes. But it wasn't just oxycodone that goes up in 96. Hydrocodone also goes up. And I'm showing you New York State data, but I could show you data from any state in the country. And I could also show you any other opioid. I can show you morphine, hydromorphone, fentanyl. You will see 1996 is the inflection point. It's the year that the medical community really starts prescribing like crazy. So again, the question is, well, what happens in 1996 to change the culture of prescribing so dramatically? And I think the best answer to that question came in a federal GAO report that was done in 2003. And in this GAO report, what they looked at was the way in which Purdue Pharma had marketed OxyContin. And this is a graph from that report. They're comparing the promotional spending on OxyContin during the first 6 years of the release of the drug to promotional spending on two other extended release opioids, the fentanyl patch and MS-Contin, which is morphine. And their point here was that Purdue Pharma had spent more than had ever really been spent before in the marketing of an extended release opioid. Now you could look at this though and hear me say that the GAO points at Purdue Pharma as why the opioid prescribing took off. You might wonder then, well, if the GAO was correct, if it was really all about the way Purdue marketed OxyContin, then why did the fentanyl go up and the hydrocodone and the hydromorphone? Why did it all go up if it was all about the marketing of just this one particular product? And they answered that in the GAO report. What they pointed out was that the bulk of what Purdue Pharma was doing was not telling doctors you have to prescribe OxyContin and OxyContin's not addictive. The bulk of what they were doing was trying to get the medical community to feel more comfortable with opioids as a class of medication. They benefited the most because they had the branded product, but they were trying to make doctors feel comfortable with opioids. And why were they doing this? Well, they had their brand new extended release opioid that they're ready to release at the end of 1995. And what did they want? They wanted a blockbuster drug, which is generally defined as a drug that brings in more than $1 billion in sales a year. Who would extended release oxycodone have been appropriate for? Patients at the end of life with cancer. Very hard to have a blockbuster drug if it's going to be prescribed to patients at the end of life with cancer. There aren't that many, and they're not going to be on your drug for very long if they're at the end of life. The way you get a blockbuster drug is to get the medical community to feel comfortable prescribing it for common conditions. And if they're chronic conditions, or if it's a drug that's very difficult to ever discontinue using, well, then you've got the magic formula for a blockbuster. But they had a problem, so they wanted to see OxyContin prescribed widely, but they had a problem because the medical community, prior to the release of OxyContin, understood that opioids were not appropriate for these conditions. Purdue did focus groups with doctors. They'd put them around a table. They'd go around the table and they'd say, "Doctor, would you treat your patient's low back pain with OxyContin, or fibromyalgia or chronic headache? Would you use OxyContin?" And the doctor would say, "No." And they'd say, "Well, why not?" And the doctor would say, "Well, I'd be worried that if I put a patient on a highly addictive drug long term, that many patients would get addicted. I'd be worried that the patient would become tolerant to the pain-relieving effect, requiring higher and higher doses. I'd be worried that even if the patient didn't clearly become addicted, that the physiological dependence that would set in might make it difficult for the patient to ever come off of the medication. So no, I wouldn't." And what Purdue did was to reinterpret very good reasons for being concerned about opioids as barriers to compassionate pain care. And they sponsored, with some of that promotional spending, in the first 6 years of the release of OxyContin, they sponsored 20,000 educational programs around the country with these messages. The messages were that we were allowing our patients to suffer needlessly because of an overblown fear of addiction. The statistic that was used to convince us that opioids would not be addictive when prescribed long-term was that much less than 1% of your patients would get addicted. We were told that, and not many of you here in the audience are physicians, and you're hearing me say this, and you're thinking, come on, you guys went to medical school. How could you be so stupid? But you have to, the messaging was very compelling. First of all, many of us want to be doctors because we truly want to help people. But the way they convinced us, and this was why I took some concern about Chuck O'Brien's comment last night, the way in which they convinced us that opioids were not addictive was sort of using this half-truth. So it is true, as Chuck mentioned, that physiological dependence and addiction are not identical. But what they told us was that there was basically a bright line between physiological dependence and addiction. What they told us was that we were mistaking physiological dependence with addiction and therefore not treating pain appropriately. True addiction was rare. Physiological dependence is normal and natural. It's going to happen to everybody. It just means the patient's going to feel uncomfortable if you stop it abruptly. That's the same thing you see with caffeine or antidepressants or antihypertensives. It means you need to slowly take your patients off. And that's clinically unimportant and addiction is really rare. It wasn't true. It's true that they're different, but they're closely related. One of the reasons that opioids are so highly addictive is the physiological dependence, that very strong negative reinforcement when you try to discontinue using. But even the perfect pain patient, the patient who always took their medication exactly as prescribed. If they've been on opioids for weeks and months and years, they have a very difficult time coming off. It's one of the reasons why we see this proliferation of ultra-rapid detox programs springing up around the country, where people will undergo general anesthesia just to get over the acute withdrawal. And the acute withdrawal is not just that people feel like they have the flu. That's part of it. People feel when they're going into withdrawal, it's like a panic attack. There's this sense of impending doom. People will commit suicide in the context of acute opioid withdrawal. It's why they do desperate things like rob pharmacies to maintain their opioid supply. But that's the acute withdrawal. What we know from studies that were done at Lexington, at the narcotics farm, patients will have months, up to 6 months of symptoms after they come off of opioids, of insomnia, of depression, of fatigue, of leg kicks in the middle of the night. And again, even the perfect pain patient who took pills exactly as prescribed, when they feel lousy for weeks and months and they know in the back of their mind, all they have to do to feel better again is to take one pill, they have cravings. So the idea of this bright line between addiction and dependence is not true. And then lastly, we were led to believe that putting patients on long-term opioids, that's the compassionate thing to do, because that's the way you're going to improve the quality of life in patients who are suffering with chronic pain. And many people do suffer with chronic pain. It's a common, serious condition. And there was an infomercial that was shown at these educational events that Purdue Pharma did. They'd put a patient up on the screen who would tell you, I was out of work for several months because I had injured myself on the job, and I had no income, and I was in awful pain, and life was miserable, but now I'm on OxyContin, and I'm back at work again. I feel terrific. I just bought my kid a bicycle. I got my life back thanks to OxyContin. And in fact, they named the infomercial I Got My Life Back because the patient had sort of said that during, and I don't even think they scripted it. The patient really said it. He really meant it when he was saying it. That patient would ultimately lose his life to OxyContin, the same patient in that video. So the idea was that opioids are safe and effective for long-term use. What we now know, especially with data that's come from the workers' comp field, if you treat an injured worker's chronic pain with long-term opioids, that worker is far less likely to ever go back to work again compared to any other intervention you could have offered them for their chronic pain. We've got pretty good data now indicating that for most people with chronic pain, opioids may not be safe or effective. They can even make pain worse. It's a phenomenon called hyperalgesia. At our country's leading pain programs at the Mayo Clinic, at the Cleveland Clinic, they're treating people with chronic pain by getting them off of their opioids, and they're finding significant improvement in their pain. It wasn't just these educational programs and advertising. The campaign that Purdue Pharma launched and that other opioid makers would ultimately join in helping underwrite was multifaceted and involved collaboration with many different organizations. In some cases, pain patient groups were created by the drug companies. They were meant to look like grassroots organizations of patients out there advocating for the millions of people suffering with chronic pain. But they weren't grassroots organizations. They were artificially created. They were AstroTurf organizations. And there were existing professional societies, the American Pain Society, the American Academy of Pain Medicine. The drug companies didn't invent them. They existed, and many of them had been doing very good work advocating for multidisciplinary pain care programs, because we do need to do a better job of treating people who suffer with chronic pain. But when the money came from pharma to advocate for opioids, you saw the messaging change, and the professional societies started to advocate for opioids. They put out consensus statements saying that we need to prescribe more opioids and that opioids are not addictive. Even the Joint Commission, which accredits hospitals, and state medical boards through their trade association, the FSMB, were involved in this campaign to encourage opioid use. And I don't want to make it sound like it was all sinister, that it was all drug companies putting money in people's pockets to say wonderful things about opioids and to lie for them. I think that most of the people involved in the movement to encourage opioid prescribing really believed what they were saying. There was this notion that we've got this gift from Mother Nature, and we're letting people suffer needlessly because we're making the mistake of confusing addiction and dependence. And I know many people who were not on speakers bureaus for pharmaceutical companies who were giving the exact same lectures and messages and writing articles. Many got caught up in this campaign. So I mentioned that we were told that the risk of addiction is much less than 1%. Now let's say you're a young doctor and you're reading a textbook and you come across this statement that, and you're reading the chapter on pain and addiction, you come across the statistic, much less than 1% of patients will get addicted. And you're thinking back to med school and your pharmacology and you're recognizing that these are essentially heroin pills. How could you expose people, many people, long-term to a highly addictive drug and much less than 1% would get addicted? So you're sort of scratching your head and you're not really buying it. So you go to the back of the chapter for the citation. This is what you would see. You'd see Porter and Jick, addiction rare in patients treated with narcotics. New England Journal of Medicine, 1980. It's in the late 90s through the 2000s. Everybody's citing this 1980 reference. Now, you might go into PubMed to try to pull it up. Nothing comes up, maybe because it's from 1980. And you look at this and you say, well, New England Journal of Medicine, that is the best medical journal in the country. And the title looks pretty good. So you might say, well, maybe it's true. But let's say you're still not comfortable. You say to yourself, I'm not buying it. I want to see what they did in this study because I can't see how you can expose people long-term to a highly addictive drug and much less than 1% would get addicted. So you make your way to the medical library and you pull out the 1980 volume of the New England Journal of Medicine. What you would find is that what everybody was citing wasn't actually a journal article. It was this. This is Porter and Jick, a one-paragraph letter to the editor describing chart reviews of 11,800 patients who, while hospitalized, had been given morphine or Demerol, and there were only 4 charts where a nurse or a doctor had documented that the patient suddenly appeared drug-seeking after being given a dose of morphine or Demerol. This, of course, would tell you nothing about the risk of addiction when you expose someone to opioids long-term. And yet this was cited over and over again. It was referred to in the popular media as a landmark study that had proven we didn't have to worry about getting patients addicted. So the message I'm giving you today, that opioids are not a good treatment for most people with chronic pain, and that in fact overprescribing of opioids has ushered in a public health crisis, has really been the theme in many medical journal editorials and in papers that have been done. This is a review that was done by the federal government. AHRQ put out this paper January of this year. I'm going to read just a summary here. Conclusion: evidence is insufficient to determine the effectiveness of long-term opioid therapy for improving chronic pain and function. Evidence supports a dose-dependent risk for serious harms. What they're really saying is we have very good evidence of significant risks to patients exposed long-term to opioids that are dose-dependent, and we don't have evidence that these are helpful to patients. So how do we bring the epidemic under control? I went out of my way to describe this as an epidemic of addiction, that this is a disease epidemic, because I think what we need to do to control this epidemic is the same thing you would need to do for any disease epidemic, whether it's measles, Ebola, HIV. How do you bring an epidemic to an end? There are really 2 things that you do. First, you prevent new cases of the disease. You contain it. And then the second thing that you do is, for the people who have the disease, you treat them so that the disease doesn't kill them. That's how you bring disease epidemics under control. And I think that's basically the same strategy we need to employ for this epidemic. And to prevent new cases of opioid addiction, it really boils down to getting the medical community, including dentists, to prescribe more cautiously. Then, of course, we have to see that people who are addicted have access to effective treatment. If we only focused on curtailing overprescribing and we do nothing to expand access to treatment, what will continue to flood into communities to meet the demand? Heroin. So, and the last point, even though I think people think of the war on drugs, reducing the supply, I think closing down pill mills and seeing that the black market price of heroin is high, or that heroin on the black market is not easy to obtain, I think that's important because it goes along with expanding access to treatment. Very difficult to get people engaged in treatment if they can easily march into a pill mill and their insurance is paying for the prescription, or they've got very ready access to inexpensive heroin. It's very hard to get those people engaged in treatment, and they're going to be very high risk for an overdose. So I think that is, supply is important. So if it's this simple, why has the epidemic continued to get so bad every year? Why is it still getting worse? Why aren't we doing the right thing for this problem? And I would argue that policymakers, for the most part, this may be changing, policymakers have really accepted the opioid lobby's framework of the problem. And from David's talk, it sounds like this isn't a new way for industry to try and frame the issue. But what you hear over and over again is the policymakers are told, well, we have two problems in America. We have the problem with these drug abusers, and we have the problem of millions of Americans with chronic pain. And your job as the policymaker is, don't do something about this problem that will make this problem worse. This slide, by the way, was shown at an FDA meeting. I was at that meeting on behalf of PROP, arguing that the FDA needed to put Vicodin into the Schedule II category. This was the other argument from an industry-funded pain organization, basically saying to the FDA, if you put Vicodin into the more restrictive category, you're going to be penalizing this patient for the bad behavior of the drug abuser, because she'll have to go to her doctor every 3 months instead of every 6 months if it's in the Schedule II category, and that would be a bad thing. This is based on the notion that opioids are helping millions of people with pain, and all of the harms are limited to the so-called drug abusers, when that's absolutely not true. And as you saw, the overdose death rate is much higher in older Americans. What Physicians for Responsible Opioid Prescribing, PROP, has been telling policymakers is we don't have these two distinct groups. There's tremendous overlap that when you look at pain patients on long-term opioids, not less than 1%, 35% met criteria for DSM-5 opioid use disorder. In a study that was done looking at people who had died of prescription overdoses in the state of Utah, in 2008, they looked at everybody who had died of an overdose in that 1 year. There were about 300. They found that 92% of the people who had died from a prescription opioid overdose were receiving legitimate prescriptions from doctors for chronic pain. They interviewed next of kin. The next of kin believed that their loved ones were also addicted, but these were patients receiving legitimate prescriptions. So I'm going to start to close it up here. This is the AIDS epidemic. And why am I showing you the HIV/AIDS epidemic? Well, I think there's been a similar trajectory. If you remember, I said there were 40,000 drug overdose deaths in 2013. At the height of the AIDS epidemic, we were at about the same number of deaths from AIDS. And then we saw this happen. We saw deaths plummet. And why did they plummet? It was the introduction of antiretroviral therapies. Suddenly we had effective treatments that could take HIV and turn it from a terminal illness into a chronic disease. And I believe we have medicines that could allow us to do that right now with opioid addiction, particularly buprenorphine, Suboxone. And unfortunately, we have not done a good job of seeing that people who are opioid addicted have access to that medication. Here's something to feel hopeful about. For the very first time in his presidency, President Obama, this was 2 days ago, It's the first time since he's been president that he actually spoke about our opioid addiction epidemic. He did that in West Virginia. I think up until I don't think his administration has really done an adequate job of handling this crisis, but he is speaking about it, and this is what he tweeted, which is a reason to be hopeful. Sales of powerful painkillers have skyrocketed. In 2012, enough prescriptions were written to give every American adult a bottle of pills. So it is good to see that the president understands that overprescribing has been fueling this problem. Up until now, policymakers have been ignoring the overprescribing. So I will stop here to summarize. We are in the midst of the worst drug addiction epidemic possibly in our history. I defer to David on that. And to bring this epidemic under control, we have to prevent new cases of opioid addiction, and we have to treat people suffering from the condition. Thank you.
We do have a few minutes for questions before we break for lunch. So if we can pass the microphone around as well, there in the back.
Most of you heard me yesterday. I'm Charles O'Brien, and I'll try to be very brief. I greatly appreciate what Dr. Kolodny just presented. It's really important. I just want to add a few things to it. I think he and I agree mostly that there really is a difference between physical dependence and addiction. It may not always be that easy. One of the things that I've done is study withdrawal a lot over the past 50 years, actually, in the laboratory with human beings as well as with animals. And I can tell you that what you said about withdrawal can be very severe, especially those cases where if you go on a website and find out about SSRI withdrawal, you would think that it's really terrible, but a lot of it is conditioned responses. There's a lot of what you might call psychological withdrawal. And I've done this with methadone patients many times, and if they think the dose is being reduced, they have a lot of symptoms. So this is something we have to remember. Now, I have railed against the Porter and Jick's paper. That's ridiculous. Just as you said, there's no evidence that it's less than 1%. That's not a study. It's just like a letter to the editor. And, but I used that actually to look for other studies. What are the good studies? And the fact is that we don't really know. I think it's a terrible thing that after so many years, even thousands of years of treating people with opiates, we don't know what the risk of addiction is. It's certainly more than 1%. And if you look at studies, you can't really tell. There's just one study, I believe, in the literature the last time I looked, where somebody studied people getting opiates for as long as 4 months. Because the issue is the tolerance, and people will have a tendency to abuse. What I did was I used this lack of evidence to get an NIH grant, which I did in a place in outside of Philadelphia, Reading, Pennsylvania, where they have a capitated program where everybody gets their drugs from the same pharmacy, and it's all covered by their insurance. And I decided to study the kind of opiate use that I recommend against generally, which is non-malignant pain, back pain, with opioids, with a new treatment. And these were all either internists or family doctors, not pain specialists. And we thought we would study them for up to 2 years. I thought they might be on for a long time. And we could tell when they were engaging in aberrant behaviors, meaning going to multiple doctors, going to ERs and things like that to get more. That would be clearly signs of at least beginning addiction. So that's what we were looking for, that aberrant behavior in our study. Well, the study is over. I told you about one of my failed studies last night. In fact, that's why you do research. Doesn't always work. What we discovered was that most people didn't want to take opiates for longer than 6 months. They stopped because they didn't like the side effects. So it wasn't as though they were all getting hooked on them. And this was a real-life prospective study where we counted everybody, and we did follow up. The study is under review right now for publication, but the point is that it didn't work out the way I expected, because I thought I would be able to follow how long the pain relief lasted in these people with back pain. And I always tell clinicians, use anything you can before opiates for back pain. Use non-steroidals, aspirin, and stuff like that, because that's much safer. But if you have to use opiates, it's, just do it carefully. And I think where we, as a medical profession, really drop the ball is in education. We don't teach people how to treat pain, and most doctors don't really know how to do it. But I just thought I'd point out that, opiates, it would be terrible if it really stopped. As a matter of fact, I've never been on the list of people who get invited to give talks for the drug companies, because what I recommend is methadone. I think that's the best long-term medication because of the NMDA receptor activity. You don't get as much tolerance, and I've treated people for as long as 20 years with methadone for pain. But in any fact, we could go on and on. This would be fun sometime for you and I to but I just didn't want to leave the group with the idea that you should never use opiates. I don't think you meant that either.
Well, I will clarify, and I appreciate your comments. I think there might be a role for opioids for people who have chronic pain conditions, particularly conditions that are prone to flare-ups like rheumatoid arthritis, gout. I think there may be a role for immediate release opioids that are used intermittently, meaning that on the good days you're getting by with Advil or Tylenol or Advil plus Tylenol, that both can be taken together. And on the really bad days, you take a low dose of a Vicodin to get by. But the way in which the medical community has been taught to treat chronic pain with opioids is to put people on extended release products where they're taking the opioid every morning, every night. They're opioids constantly in their system. Hard to even know if your pain condition had gotten better because you're on opioids chronically. And within a week, you've made that patient physiologically dependent. And a few weeks or months, it's going to be a person who's going to have a very hard time coming off. And again, the best evidence is showing us that the patients who've been put on this treatment have very bad outcomes. And I'd be happy to show some of that data share that data with you. Thanks.
We're running out of time rapidly, but perhaps one more question. In the back there.
Dr. K, you're amazing. Thank you for your presentation. I just had one question for you, which is, you noted 96, 95, 96, 97, that as being the area of escalation of opiate dependency. And the other thing that happened during that period of time was we got mail. We all had access now to an international database to buy free bad drugs. And I don't know about anyone else, but I got endless pop-ups and all this stuff. Are you in pain? This is cheaper than your pharmacy. Have you calculated or done any research on the effect of the internet and people's ability to buy prescription drugs on the internet, which came about right around 96, to the escalation of the problem?
Yeah. I haven't. For a while, Vicodin was available easily over the internet. That ultimately changed. My guess is that people who were purchasing large quantities of Vicodin over the internet are similar to people who seek out pill mills. They're individuals who've already developed the condition of opioid addiction, and that much of the addiction develops innocently. It's the well-meaning docs who are inadvertently either getting patients addicted or indirectly causing addiction by stocking people's homes with opioids.